Thanks for joining us today.
Greetings to everybody from just south of Portland, Maine, on the east coast of the United States. So good to be here with everybody.
It's so good to have you on the show again. We have a lot to do today. And one of the courses I had to take in my graduate program was about patient interaction. And the author of the book, Patient Practitioner Interaction, is Dr. Carol Davis. And so Carol, as I mentioned, has over the last 25 years, she was part of my doctoral dissertation. She was the reason why I went to University of Miami. It was Dr. Nancy Bill and Darcy Umfred, who were my sort of mentors out in California, who said, you need to go back and get your PhD. And so as I did my research, it came down to two universities, WashU and University of Miami. And University of Miami was a choice because of Dr. Carol Davis. So when I met Carol, that was it. We fell in love, and we've been collegial lovers ever since. So we're best friends, and I'm so grateful for your mentorship and leadership and calmness when I was a little out of control in my doctoral dissertation stage and late on chapters for books. So good to have you with us, Carol.
So great to be here, Brent, and thanks for recapping that wonderful history that we shared. It was great living together and being with you, and then being at Polestar from 2003 to 2015, treating patients right next door.
All you brought in, so many people that have blessed our lives from our relationship, and the people that you've brought into Polestar. Elizabeth Jimenez was thanks to you, and she's been our rock of administration, and also my personal favorite myofascial release therapist that you brought, and she has saved me time and time again with great treatment, and we certainly appreciate that relationship. So last time we talked, we were talking about sort of myofascial release intervention from a manual as well as a movement integration, and so that was our last discussion for those of you who joined us with Carol's last visit. Today we're going to be talking about sort of our role as practitioners, and I'm going to use that word consistently today because we have Pilates teachers and physical therapists and chiropractors and OTs and many other types of practitioners that are on the call today. And so I'm going to use that one generally, and we're basically looking at our role in interacting with our patients or clients as a practitioner. So when we refer to practitioner, we're referring to everybody that's attending, and it's not specifically to one field. Even though Carol and I both come from the physical therapy world, we certainly appreciate all of our collaborators in healthcare, from physicians to every aspect, especially Pilates teachers in this meeting here. Carol, any thoughts before we get started? I'm going to put that Mentimeter slide up in just a second, but anything you wanted to just say as part of an introduction to what we're going to talk about? I know we want to get their input before we do too much, but any things that are in your mind right off the bat?
Well, Brent, as I said, it's just such a pleasure to be here and talking about one of my favorite things to think about and talk about, and that is the heart of interaction when people come to us for help. And how the interaction itself becomes part of some of the most important aspect of our therapeutic toolbox that we have to give to patients in order to be able to facilitate their healing process. We don't heal, but the body heals itself. We can facilitate it. And in our interaction, as any of you have been poorly treated in healthcare, you can know this. The interaction can actually get in the way of effective healing, but it also can engender trust and a relationship that gives you the ability to facilitate that healing process in another person. There are certain things that we can look at that make such a huge difference in the lives of the people who come to us for help, and that's what today is all about.
Yeah, I have a funny story. When I first started private practice, I had a partner with me, and he was also, we both went through all our manual therapy training. We were so excited about our manipulation skills, and Bill Boysenot's class on differential diagnosis and all these things in Sacramento. And we got to the point where he said, hey, Brent, I don't want to take any of the psycho patients. You take all the psycho patients, and I'll take all the pure orthopedic patients. And the next thing, now, totally inappropriate, but listen to the story. So the next thing you know, I have 40 patients a day. He has 1 patient a day, right? And he's like, what's going on? I said, we're all psychological. We're all emotional people. You don't have good bedside manner. I do have good bedside manner. You know, I communicate with people. You don't. You talk down to them. I talk to them. So look at the difference. I make a lot more money than you do because I have more patients and more relationships. So that was a very immature first introduction to the idea that, you know, in our practices, it's so important, this human element of connecting. And that's really what we're going to be talking about today, is that connection. Of course, that education deepened with Dr. Helen Mason's work in looking at cultural diversity, looking at neurolinguistic, your work with interviewing and patient interaction, which we're excited to talk about today. Melissa, let's bring up that Mentimeter slide. Let's just see where people's heads are at today as it pertains to the role of the practitioner. So while you're doing that, we're going to keep it hidden for a little bit till we get a good response there. It's looking like we are about 100 people live right now. So we have about 650, 670 people signed up for it that will get it afterwards. So if you're getting this afterwards, go through the same process. You won't be able to do it on Mentimeter, but just write down what you think your role is as a practitioner. Let's see what we're looking at. All right. So what do you think, Carol? Are we pretty happy with that?
Seems like we're moving in the right direction.
It certainly does. So what we'd like to do is I'm going to turn the time over to Carol, and Carol's going to take us through a mindful activity that has to do with our experiences. So
can we stay here just for a second? There are all of these answers are appropriate.
Correct.
And we would be involved in every single one of these responses at some time or another. The question is framed in a role kinds of question. And what we're going to focus on today is the nature of the relationship between you and your patient and how you can go about engendering the best response. And now we'll go into that process, but I just didn't want to move off of here by having anyone think that there was a wrong answer on here. There isn't.
Yeah, I appreciate you bringing that up. And we certainly address our clients in all of these in different times and different periods. So
right.
At least I know I do.
Sure.
All right, Carol, you are on. Let's go through our little mindful experience.
I'd like all of us now to kind of center ourselves and get yourself centered in your chair. If you're standing, that's fine, but get yourself centered so that you can feel your feet on the ground. In fact, my chair's a little elevated. I'm going to lower myself a little here so I can really feel my feet on the ground. And I want you to just put your hands in your lap and put your feet on the ground, and then close your eyes if you can. If you don't want to, just look down and just listen to my voice. But I'd like you to now just take a deep breath and move your attention into your body by focusing the flow of the breath in through your nostrils, down into your lungs. Pulling your diaphragm down with the inspiration. Inspire all the way up to your clavicles, and then breathe out. And breathing in, tracking your breath, it's what it's called. It's a mindful experience, because what we're doing is getting out of our attention and classroom and taking notes concept and getting into experiencing what it means to be present in this moment in our bodies, listening to my breath. Listening to my voice and tracking your breath. And we're just going to quiet down now. Breathing easily, feeling at one with yourself in the world, nothing to do, nobody to impress, No wrong, right answers, just be. Be with your breath. And I'm reminded of that wonderful section in the Desiderata. You are a child of the universe, no less than the trees and the stars. You have a right to be here. And whether or not it is clear to you, the universe is unfolding exactly as it should. We are all connected. Congratulate yourself for coming to this to benefit you and your patients and your clients. And I'm going to just use the word patient because that's my orientation, but you use the word client or patient, whatever you wish. But right now we're going to shift the focus in this state. And I want you to pretend for a moment that you are the patient. You are the client. And you've heard about this great place where they do pilates or Pilates or something. You know very little about it, but you have pain in your body. And one of your good friends said, these people can help you. Go see them. And you walk into this strange place. You look around at the environment. And you see, is the environment welcoming? Is it relaxing? Is it put together beautifully, artfully? And then your therapist comes out and escorts you back into an area where you can get to know each other. What's that area like? Is it a large room with other people? Is it a smaller room, quieter? What would you like it to be? You're about to tell your story, at least some of it. And now your therapist asks you some questions. And you try to find a way to express what brought you here today. How is that therapist listening to you? Is there a preset form that you filled out and they're reading the form? Or are they asking you to tell them a story? And then the therapist gives you some sort of instructions, and you go about getting started. And now we're going to stop there, and I'd like you to just take another deep breath and open your eyes again and come back into the room, into this space with us, where we're all 96 of us connected around the world. And I'm wondering what it is that you felt when you put yourself in the place of that person who comes for help, especially a person in pain. And I wonder if you felt, if you're anything like me, some anxiety, a little bit of what is all this stuff about? What's all this equipment? So many of you have been doing this many years, and you have to go way, way back to be naive about what is this reformer Cadillac thing? What are those pulleys and stuff? It almost, people I've heard say, it looks to me like torture equipment. I mean, and then we laugh, of course, because we know it's the opposite of that, but they don't know that. There is anxiety there. and you are the expert, and they've come to you hoping that you will show them your expertise. And there are two ways to approach this. And when we first go through the Polestar training, or the training to be whatever discipline you are, you're given information and knowledge, and you take notes, and you're tested on your knowledge, because the people who are guaranteeing that you're safe and qualified to work with people have to show some sort of accrediting agency of all types that you are safe and knowledgeable. So when we first graduate from our experience, and I'm speaking for myself now, which was about 50 years ago, but I still remember what it's like. What seems most important at that point is to assure this patient that they came to the right place and that you know what you have to know in order to help them. Excuse me. And the way you demonstrate that very often is that you go immediately to your, or if you're like me, to your left brain and say, oh, I think we've got just the thing that can help you with that. And then you get into starting to explain to people in an effort, and almost, and this is a confession of sorts, in an effort to reassure me and the patient that I know what I'm talking about here, that I'm qualified. And that's just a very natural thing to do when you're a new graduate, when you're new at a skill and in a helping profession. We like to see that in medicine and healthcare, especially, as the vertical approach. There is the wise one on the top with all the knowledge, and then there's the patient down here. And the patient is a passive recipient of your knowledge and your expertise. They tell you enough to get you started, and then you get started, and you work with them, and that you hope that something clicks, hope that something works. And then you discharge and hope that they'll come back the next time, or you give them an appointment to come back the next time and see whether what you did helped at all. Now, that certainly is an age-old approach to patient care. And as I got older and became more of a patient myself, I started to shift in my orientation. Brent, did you want to add something?
Yeah, I was just watching the news the other day, which I'm trying to do every day because it's so distracting. But there was a thing where a physician was being interviewed, and he was the chairman of one of the medical schools. And he said, well, as you know, and exactly you talked about, he created the vertical approach to patient care. He goes, I have 5 minutes to come in and discover what's wrong with the patient, diagnose and prescribe. And that's what we have to teach all of our doctors to be able to do, right? So, and I sort of laughed because I thought, it's so interesting that we have become, the model has always existed, but the model's been exacerbated because of maybe healthcare reimbursements and the amount of time that you have available to spend with a patient, that we get to the point where we think like, look, I just got to be the best diagnostician. I got to be able to walk in that room, tell them what it's going to be, and 5 minutes later, write the script, send them for the tests they need, done, right? And it's so interesting how we have shifted so much in consciousness of the patient now being the consumer, and patients going like, I left that practice because I never was even able to talk or say what was going on with me. I was like, I literally had 5 minutes. I waited 2 hours in the waiting room, and I had less than 3 minutes with the physician, and that was it. So I've gone to paying cash for a functional medicine doctor who actually spends an hour with me and listens to me, and we work on it together. So I think that's, we are in the crux of this transition. And of course, you've been a leader in this area for a long time of trying to get more horizontal. And I'll share one other thing that was a very big part. Most people know I had my hip replaced almost 2 years ago next month. And when I was looking for doctors, I interviewed surgeons in Chicago, in New York, in California, in Colorado, and in Miami. And I finally went to, two of our famous docs in Miami at Baptist that are doing total hip replacements. And I sat down, and Dr. Suarez, he doesn't mind me using his name, sat down next to me. And we looked at the MRI and the X-ray, and he said to me, "What do you think?" And I said, "I think you're going to do my surgery." I knew in that moment, they all had the same skill set. They were all trained in the same procedure that I knew I'd wanted. But when he said that, when he sat down next to me and he said, "What do you think is the right thing? I know you're educated. I want to hear from you." And
Wow.
it was so refreshing. And I said, "Dr. Suarez, you might not even know this, but that's what I was looking for, was somebody who would respect the fact of what I've been dealing with my hip for the last 30 years, and also professionally for 30 years, and thinking of how we could have that dialogue sitting side by side, looking at the same thing, going, what are we going to do? How are we going to do this together?" kind of thing. That was it. I told him, "You're going to be my surgeon. I mean, it's done. When can I get on the table?" And I had a wonderful experience and a wonderful outcome, and I still have a great relationship with Dr. Suarez.
Great. And he understood what we've come to call patient sovereignty. Patient sovereignty. Now, there are many, many patients who are not like you, Brent. I'm so glad you brought that in. There are many patients who are not like you, and they have said to me, "Just fix it, doc, just fix it. I don't care. I don't want, you just fix it."
Yeah.
They're sometimes the most challenging, because I certainly don't want to exclude them from the decision-making process. But how I engage them would be very different than how Dr. Suarez engaged you. And so it has to be very individual, doesn't it? You have to know a little bit about the person and their history. And so what I'd like to do is start building a horizontal model, and that is a kind of a collegiality, where there is a democratic relationship between you and your client or patient, and that you gather information, enough information. You have let's back up a second. The environment into which the patients walk is a soothing environment that engenders trust. It's an environment that doesn't emphasize technology. It emphasizes, perhaps the walls are painted a soothing color. Your front desk people are kind, and you enjoy talking with them, and they remember your name. You do a lot of education with the front desk people as the interface of your practice. And then as the patient moves in, you have a way of being able to get enough information from that person, and then at the very outset, look, I know quite a bit about the skill set that you came for, but I don't know you, and I don't know your body. You know.
I like that.
So we are going to be in a collegial relationship here, where you're responsible for talking to me about your body and how this is impacting you and what you think would work and what your goals are. And I'm going to be listening very carefully to what it is that you want to achieve. And I will orient what I do toward your goals, not toward mine, or what I think the books tell me.
Yeah, and I remember in your book, there's a paragraph, and it says something that I've carried with me forever, and I teach it all the time. But it's like the patient knows what their body needs. They just don't know how to articulate it.
Yeah.
And so it's up to us to facilitate the storytelling.
Right.
How do we facilitate that storytelling? And it's so amazing. I mean, I have story after story after story of patients who end up telling things that are completely 180 degrees up or out of left field compared to what I would have come in and asked, and I learned very early. It's like, look, don't, things like, so where does it hurt? Well, who said it hurt?
Exactly. Yeah.
Right? Why would you make an assumption? Right? So I've changed my language a lot to things like, so what brings you here?
What brings you here today?
Right?
And what's different this week than the last time I saw you?
Yeah. Or what are you, is there anything that you're feeling you're not able to do? Is there anything you're limited in being able to do? And what do you think is limiting you in being able to do that, because you probably know best. Or when do you have those symptoms that you're complaining about? Oh, I have it at night. Okay, interesting. Is there any activity? It's like they know. And I think that's the cool thing is and you talked about the patient or the client that has the expectation of fix me. Just fix me. I'm here, do the manipulation, fix me, right? Or the patient or client that says, I schedule my vacations around your vacation because that's how important you are to me. And it sounds great. Nice little pat on the back. Major psychological problem, right? Complete loss of independence, complete loss of self-reliance. They no longer feel empowered to take care of themselves. We've created a very dependent, situation that is very unhealthy for both the practitioner and for the client. And so a lot of times the questioning that we've rehearsed and the things that we've learned, and we've taken these courses and we've read these books, and I've heard you speak, and cultural diversity. There's so many things that are factors, like an ICF model. The other day we were teaching a lecture at the university, and my partner in teaching brings up the ICF model, and he was going to blow over the personal factors. And I was like, whoa. My whole dissertation was on the personal factors and how the psychosocial measures were far more predictive of outcome and well-being than any physical limitation or structural limitation in these models of health and disability assessment. And it's just so important to me to always be, in that space. And I think that's something that I've had intuitively that I've been able to enhance with the science and the psychology. Your doctorate degree was also in the psychology of health and well-being and education and patient care. And, it's like bringing that knowledge to what I felt in my gut or what I felt in the empathy or compassion, and being able to structure that patient interaction in that horizontal space, sitting down the same way, matching body language, asking the question rather than telling the answer. So many of those bits and pieces have been, crucial to the success of my practice. That, it's like I look back over the last 30 years and I think that, all the skill sets, all the science, all the manual therapies, all of the movement integration that is a skill set that I've acquired over these years is nothing compared to the human relationship or communication in helping people figure things out for themselves. It pales in comparison to these skill sets we're talking about today.
So let's go on in that vein, and let's talk about what are some things that you already know that you can put to use once you have a basic understanding of the medical and the physical things that are the patient has come with. And I want to emphasize the whole idea of curiosity and listening with curiosity, and trying to, if you feel yourself judging, be sure to pull back right away, because that judgment will tend to project something that might not be accurate. And so when you want to feel judging, pull back and be curious and say, what's going on here? Where did I feel that inside me? So now we talked about a soothing environment. We talked about getting good information and finding a way to get information by generating some questions all in advance so that you can know what to ask and the sequence to ask, and then doing active listening. And what is active listening? Well, a lot of people will listen with the idea of wanting to insert their point of view while you're still talking. That's not active listening. Active listening is listening to not only to what the person is saying, it's looking at the body language, as Brent pointed out, and it's listening with that third ear. It's the intuitive ear, the heart ear. And what is it? What's the emotion behind this? And what is it that they might not be saying that they're a little shy about? And the way you can get at that is there anything else that you wanted to tell me? I had a sense that you were leaving some things out. We can do it next time if you'd like, but is there anything else you need me to know right now? Another way is to be able to make sure that it's a kind of a fluid relationship. They might come in for the second, you might come in for your second visit, and you're gonna connect with your therapist, and as therapist, you're gonna connect with your patient and just get a sense of where they are at this point in time, different from where they were last time. And sometimes it's helpful for patients for you to recollect, well, last time we spoke, you were really kind of focused in this area. Has anything changed? Or what kind of things do you want to talk about now? And if they don't have anything, you say, well, let's just see how things are. And if you're doing mat work, you just get started with moving, and then you do your skills of the broad view, scoping out the broad view, not focusing in immediately on a joint, but scoping out the broad view and getting a kind of a sense of where this person is, with your curiosity going, now how does this that this person is relating now to me in movement respond to the last time that we spoke, so that you're building a kind of recognition of where you want to go. Brent.
I was going to mention that, you said something really important there that I want the audience to make note of, like to write down. And that was your pre-framing of your session. You created the safe environment to talk about. I think of myofascial release sessions where you create the safe space,
And that emotion is very understood and heartfelt, because
it's emotional because I've been through that before. I
know that you were just focusing on a moment that you felt that with your body, with your interoceptive system. And it's important that as therapists, we notice that when people kind of stop and swallow and clear up. We might ask about it right then, or we might just let it pass.
Or just let it pass. I mean, I think a lot of times, you don't know why the emotion is even there. I mean, it's like, I remember being in your hands and you saying, it's okay. It's safe.
I remember the same thing with you. Louise Lang was working with me, and I had this terrible lateral hip pain, the bursitis, and I just couldn't move through it. And I just kept pushing and pushing and pushing. And then the tears were flowing out of my eyes. And I got up off the table, and Louise said she just needs a hug, because Louise didn't know what to say to me, and you just enfolded me, and I sobbed, and you said, you're safe, it's okay, just go ahead, just let it out. And boy,
that pre-framing is so powerful, and I use it sincerely and genuinely. I think if you used it as a recipe in your agenda, it won't work. But the idea of asking that question, is there anything new that you would like to talk about, or anything new that you observed this week? Or anyway, and even if they go no, what we've done is we've created the bucket. Now we can do the opposite. Remember how you said we can create the negative experience as well? If I said, is your pain hot, dull, throbby, achy, pinchy, icy, cold, hot, right? It's like they're going to look at you and go, yeah, it's all of those, right? So we can create the influence, but and I think this is the key difference, and even in your book, and I suggest anybody, we'll talk about the book later, we'll give a post of it, but in your patient interaction book, in the interviewing questions, the questions are open-ended. They are not influential questions of how they answer. They are open-ended questions to allow them to reflect and to articulate. And we're often so much in a hurry that we answer the question for them.
Right.
Hey, so where does it hurt? Your foot, your knee, your leg, your back? You got pain down your leg? And they're like, wait a minute, I'm trying to process it. I've never thought about it from that way, right? And one of the things teaching the students is like, shut up. You ask a question, be quiet. Like, let them go through that process and dig. And that's why the questions are things like, is there anything new that you want to share? You're not making a judgment there that they have something bad that happened. We don't ask the question, did you have a lot of pain yesterday? Right?
Yes, no.
It's not, it goes nowhere. It doesn't have anything, right? It's like, what's new? What are you experiencing? And I love that. And I think that, and I sort of have my own scale of how I judge internally how my patients are doing, right? So my thing is, instead of a pain scale, I have a function scale. And if they're able to do everything that they had on their agenda to do, sort of tying into the ICF model, if you're able to do everything you needed to do, no matter how bad the pain was, but you did everything, that's a 4. And if you couldn't do 25% of your daily activities, that's a 5. 50% a 6. 75% a 7. 100% a 8. 9, you're in the hospital. 10, we're basically knocking you out of the hospital with, anesthesia. But my point is, I don't necessarily share that with the patient, but it's my way of judging function and asking questions of function rather than pain. And maybe I'm biased because I work with so much chronic pain, but I don't focus my intervention on the pain. I focus it on quality of life. I focus it on function. And it's amazing how these simple words that we're talking about right now completely influence the patient's outcome.
That science has been very well established.
Bandura, Flexner, there's lots of...
We call it rapport or bedside manner. But these kinds of listening skills take a kind of an inner patience on your part as a practitioner. Very often you have so many good ideas about what you want to do with the patient, and you just want to get started, and you want to try and get as much done as possible with that person, with the idea in mind that the more you get done, the faster they're going to heal. And so what Brent and I are trying to emphasize with you today is actually pull back a little and give yourself at least 10 to 15 minutes of interaction. It can be movement interaction, but interaction with the patient without an agenda in mind. And then in that time, what I'm going to suggest to you is that there are different ways that you can interact and characteristics. This is what I did my dissertation on when I was in school ages ago. And it was entitled A Phenomenological Description of Empathy as it Occurs Within Physical Therapists for Their Patients. And basically what I did was I interviewed physical therapists about the nature of their interactions. And I stated up front, in the literature, there's a distinction that's made that's not made often in most writing. There's a distinction between sympathy and empathy. And sympathy is seen as fellow feeling, kind of you and another person feel emotionally aligned with something. We both might be excited about what a beautiful day it is, okay, or sad because it's not a beautiful day. That's emotional alignment. Empathy actually has something else. But before I go into empathy, let me say that there's sympathy and then there's pity. And a lot of healthcare practitioners, and myself included, feel pity, but you don't want to admit it. And pity is sympathy with a kind of a hierarchy there, but for the grace of God, go, you poor thing. Yeah, you poor thing. And it's interesting because now my lower extremity weakness requires that I use wheelchairs for long passages in airports. And I remember that I used to see people in wheelchairs and feel sorry for them. Instead of seeing the person, I saw the chair. So pity is a little bit, is like sympathy, but with a hierarchy. Self-transposal is what empathy is usually defined as in the literature. It's putting yourself in the place of another person. It's very cognitive. Identification is why people don't want to, young therapists and physicians especially, don't want to learn empathy because you're afraid you'll lose yourself. I get so much going on their story, I can't be objective. I can't get myself out of it. That's identification. That's not empathy. And then empathy is a combination of 3 of those things all happening milliseconds together and given to us after the fact. Let me explain. Empathy is first a lining up with someone, and then you get so identified with their story, it affects you emotionally. You go from your understanding part down to your gut. And then you say, wait a second, that's not me. You're not me. And you get yourself back very quickly. And that's the package of empathy. A very quick story, a physical therapist was working with a patient in a rehab setting, and she had known him for a long time, and he was a patient with a spinal cord injury, and he was getting ready to be discharged home. And he wheeled himself into the rehab area, and she saw that he was there, and she was working with another patient. And she said, go ahead and transfer to the mat, David, I'll be right with you. He was able to transfer safely by himself. And she noticed that he didn't do that. He just stayed in his chair. And she repeated herself, and he didn't do anything. And she said, I'll be right with you. Finished up with her patient. Went over to David and realized he was emotionally upset, so got him into a private area. And she knelt down his level and said, what's going on? That's it, just what's going on? Talk to me. And David said, my brother and my fiance just announced that they're in love and they're going to be married. And he started to cry. Well, she started to cry too. This was a long relationship. And she thought, wait a second, this is him, this is me. So she reached out and touched his hand and said, oh, David, I am so sorry. And so she was able to establish the link without getting lost in the emotion. Now, all of this is empathy, the what's going on, the identification, and then the sympathy together. So what I'm asking for you to do is not be concerned about your vulnerability when you're speaking with patients about things that are very personal. They're coming to you because what's wrong with them is very personal, and they want you to hear them on a personal level. They'll communicate with you appropriately to the level that they want to disclose. You can be open and listening, and you can say, is there anything more you want to tell me? But you never push. You never ask private questions unless it's important for you to know as a part of avoiding dangerous areas, risk areas. But when you speak and when you listen, give time and recognize that mammals, especially mammals, because of the way we're put together, and the vagus nerve and the ventral vagal system, we love to feel as if we are listened to and held in this anterior area. And that's why we like face-to-face. The pandemic has been terrible because we're on these Zoom calls. We can do a little through eye contact and through the tone of our voice. Are you very direct, and are you talking like this, and are you teaching? Are you being very didactic? Or are you modulating your voice? Are you listening carefully to how your voice sounds? Are you talking to others the way you would want to be talked to? Or are you listening to others the way you would want to be listened to? Those are the key questions that you ask yourself in order to be able to be emotionally responsive. There's marvelous stuff going on in fascia science and in neuroscience and the interoceptors. The interoceptors are 100 times more numerous than the other sensory nerves. And those interoceptors go into up the spinal, spinal thalamic tract, but then they go over to the insular cortex, over to the limbic system. And it tells us how we feel. And how we feel has everything to do with whether we are relaxed enough, the vagal response, not sympathetic and anxious and worried and hyperactive. Relaxed. Let's take a deep breath here. Brent has a marvelous way of doing this with his tone of voice, with his manner, and many of you do too that I've met in the circuit as I've talked at the different Pilates, Polestar Pilates conferences. You're known by your patients for your interactive skills. We're just parsing out what are the elements that you're doing, perhaps automatically, but other people can learn them too. It's no longer.
I was just going to say, reemphasize that, Carol, reemphasize that so many of them, as you said, do things so well. It's like I realized there was something I was doing that was right. I just didn't know the science of it. I didn't know the skill set of it, but they were some of these behaviors. And then being able to refine them and acknowledge them only made the communication and sometimes the where the ego interferes with the experience, to be able to set and recognize, oh, that's fear, that's anxiety, that's ego. I can set that aside. That's not part of my tool chest when I'm in the treatment room. Treatment room, I am present, right? And this is something that, I remember working on, was using these very tools of how can I be completely present with my patient or with my student or with my client in that moment, and not be distracted by, looking for the compliment or looking for the appearance of being knowledgeable, or, all those things that are very immature elements you mentioned as a young practitioner coming out. It's like we sort of have to justify ourselves and our existence in those first couple of years, but learning to recognize it and acknowledge it, and then having the tools, I mean, it's so powerful for the practitioner. I'm so grateful for that training.
Right. Getting feedback from good friends is a way to practice as well. You can develop your skills, but this mindful awareness is facilitated by, if before you go into the session with your patient, you take a breath. I wash my hands between patients, and that's of course encouraged now, especially, but it's always encouraged.
It's not just hygienic, it was also emotional washing.
You let go of what's happened with that last patient, or with the discussion in the department,
right,
or whatever, and what's pulled you off center, and breathe. And then I ask for help. May I be present in the moment and listen with my heart and lead with kindness, and not have anything get in the way of that meaningful exchange with my patient, being fully present. Those are a couple of clues.
Sure, I want to finish up. We don't have a whole lot of time, and there was definitely some comments and things that people were, agreeing to the comments we were talking about, and some, challenging. There was one that came from D. I know you can see it as well in the questions. And before we finish up, I want to just think about going more into the physiological and aspect again, a little bit deeper, of connecting, and the touch or the communication, the eye contact, the body language, or movement and movement instruction cueing, how our intention in those parts of our treatment also create that trust in that relationship. And while we're thinking of that, let me just read. Dee said, it sometimes feels like most clients need to travel through this journey from the fix me attitude towards the self-care and self-discipline awareness. They need to allow themselves to heal. And she said, this includes myself, by the way. What are your thoughts on helpful ways of interacting that will facilitate and speed up this process of moving from the fix me attitude to taking responsibility and the discipline? And I will add to that is a basic fundamental belief inside of the Pilates philosophy. Joseph's, he had his 3 guiding principles. The second was whole body discipline, right? It was the ability to have the work ethic and the discipline to live a whole body healthy lifestyle. And so one of our responsibilities, if we're really promoting health, and I would extend this to all of healthcare practitioners, is how do we educate and facilitate the practice of healthy lifestyles and ownership of those healthy lifestyles with our clients. And Joseph had mentioned that if we practice Pilates every day, and he didn't call it Pilates, he called it the contrology exercises, that there would be no reason or need for hospitals, prisons, or insane asylums. It's quite a statement, but if you think about it, if we all have moments of being present every day in our body and being mindful, I can't promise the mental health and the physiological health, those things, but the likelihood of doing something that would lead you to prison, I bet you would greatly decline. People that are present tend not to do, violent acts of passion or those kind of things. They tend to be, they don't think after a yoga class, hey, Carol, let's go rob a bank. It's like, it's not part of the vernacular when you follow a mindful moment. And so how do we create that? And I think COVID, Carol, has really helped us understand that our clients have the capacity to take on the responsibility of being healthy and practicing their exercises and doing it every day. And so many of them have noticed and said, wow, I never did mat exercises before, but since I was resigned to only take mat every day online, I have fallen in love with it. And I feel so much better than I even did when I was doing the private sessions, you know, as Juan Nieto calls the butler sessions, of having my hand held and my gum held and somebody putting straps on my feet, to me being able to really learn and listen to my body and be able to exercise it and have that responsibility. And that goes right back to Joseph's original concept. And it's this distortion of what we call healthcare, at least in the United States and Western medicine, is that it really is disease management. It really isn't health promotion, right? We're trying to move in the direction of health promotion, but that is people learning and taking responsibility for their health. So that's my number one thing for Dee. I don't know if you had anything else you wanted to add to her, like transition.
Yeah, I just wanted to mention that when people want to be fixed, they are afraid, and they are, I think, somewhat annoyed that they can't fix it themselves, and so they have to go for expertise. People will always try to fix it themselves for as long as they can. And then when you're working with them, they'll want to work twice as hard so that they can get out of there quicker until they start relaxing and enjoying the treatment. And your job is to listen to that. And I don't know about you, maybe some of you are like me. I have peripheral neuropathy. So there are things, and I also have extreme fatigue with chronic Lyme, right. Epstein-Barr level fatigue. But I'm a physical therapist and I was an athlete. And my former idea of myself is always looming in the background. And the admonition of, are you sure you can't do more today? Are you sure you can't do this for another 15 minutes? When my body is saying to me, Carol, you've got to stop now. You've got to rest. You've got to skip those resistive exercises today. Your body needs to heal. We know now the physiology of that. We know that's heavy duty resistance strengthening every day. The fascia and the myofascia never gets a chance to benefit from that because the sarcomeres are constantly being torn down through the exercise process. We need rest to heal. You can encourage your patients to listen to their bodies. So somebody says, would you just please fix me? Then immediately what I want to do is say, let's take a second here, because I'm a manual therapist. Let's take a second here to feel now inside your body. Feel where my hands are. Bring your attention down. And they are going to be resistant to getting some of them getting out of their heads. What do you mean, bring my attention down to your, just breathe right into my hands. Breathe into my hands. Now feel into my hands. And then your instructions to your patient are, you stay within the parameters of what your body is telling you is right for you. Don't worry about being lazy. Don't worry about being angry with yourself for not doing it correct or enough or right. You've got to give yourself a break here because these aren't normal times. And what you need to do is pay attention in a different way to your body so you can feel and listen to what your body's asking for and when your body's saying, stop. So many of my patients with fibromyalgia have come to me and they've said, oh, they gave me these exercises and it hurt more and the massage was deep. It was, and their bodies were screaming, get out of there. And that is true. That's what we have to do for patients with fibromyalgia. Listen to your body. Teach your patients to listen and not admonish yourself for not doing enough. Keep to a schedule. You got to keep to a schedule in order to show improvement, but do not force yourself to go beyond what your body's ready to do.
And that load principle, Carol, is probably the most challenging thing we as practitioners have to understand, whether it's how much springs we use on a Pilates machine or what the pressure is of our hands or how deep we go with the manipulation. And, you know, this is why I sort of wanted to finish and wrap this up, is that if we are present and really connected with the patient, we will know. It's like somebody says, how hard do you push? Enough. I push enough. I know, I've learned to listen to the signs of what the eyes are doing, or their teeth gritting, or the fear that they might have if they're going to have a manipulation, or what the machines look like. And, Shelley and I go round and round on this one, just in a very positive way of talking of, rather than telling the patient or the client what they're going to feel with the Pilates exercise.
Yeah, right.
Is ask them. Shelley's a master at this. So what did you observe about that? What happens if you move your pelvis in this direction? Then what do you feel? Well, it's this constant mixture of internal and external feedback. We're the external feedback. But if we only give them external feedback and we don't ask them what they feel or what they observe, or if they notice something different or change, by us making subtle changes or doing subtle changes in the pressure that we apply to certain parts of the body, then they don't have a learning response to it, right? And one of the things we talk about in Polestar in our mission statement is to educate and practice. So the idea is, how do we educate them to become more mindful and to practice mindfulness and to be disciplined in their mindfulness, as you're talking about, Carol? It's like, working with young dancers, adolescent dancers come in and they feel the pressure to perform when they're going through major body changes at 14, 15, 16 years old, right? And some are amenorrheic, like they're 16 years old, they haven't had a period yet. Their legs are growing long, their growth plates are wide open. Their muscles and fascial tissues feel short to them compared to when they were 12. And they feel like somebody's whipping them. And it's the thing that I continue to express to them is like, you must listen to your body. So it's almost like a joke to them. They walk in, they go, it's my body, I take care of my body. And it's like, that's right. It's my body, I take care of my body. And to be able to listen, and I think this is a great place for us to wrap up, is the idea of transferring that internal feedback and letting them be empowered. And I think this is a key word I learned from you as well, but being empowered with the decisions they make by listening to their body and being educated and being able to come back and say, this week was a difficult week. And so I rested. And it's like, you get 10 stars. Good job, right? And what are we going to, what are your plans for next week? Are you feeling better now? Yes, I'm feeling better. I'm going to gradually increase load in my activities as I tolerate it, And you also brought up another really important point, and that is rest. And I can't emphasize rest enough. One of the things we saw in the dance world is that they dance 7 days a week. And in a company of 47 dancers at that time, they had 54 workers' comp claims. Every single dancer had a workers' comp claim. It's like, you guys, you can't run or dance or work 7 days in a row, because that means you never have a day of rest. You must take a day of rest. And we know the statistics now for running, right? We've been interested in running. If you run 7 days in a row, you're going to have a 68% likelihood of having a major repetitive strain injury. Right. If you run 6 days in a row, you have a 30 to 40% likelihood of having a repetitive strain injury. If you run 5 days intermittently in a 7-day period, your risk of injury goes down to less than 10%. So it just tells you exactly what you're talking about, Carol. Like, if we listen to our body's tissues talking to us, are we hydrated? Are we vibrating, with Mother Earth? Are we earthing right? Are we moving our bodies in a way that we don't get stiff because we're listening to our bodies? We're not listening to, you have this workload you have to get done in front of that computer for the next 10 hours today. No, you have to get out of that chair. You got to move. What I'd love to do is we have one more slide we want to bring up as the final slide. And Carol and I wanted to do this as a way to conclude. Then I'm going to turn over to you, Carol. Any last minute things that you would like to discuss while they're sort of answering the slide, or to leave with them as a message about that patient interaction that sort of comes to your mind. And we can discuss that while they are answering this question. What was your... This
is an open-ended question. There are no right answers. It's just your own takeaway and how that will impact you in your relating to your clients and patients. Maybe something you realize you'd like to change. Maybe that stopping and washing your hands or centering yourself and breathing before you go in. Maybe changing your ideas about rest. What's your key takeaway, and how will it impact how you will relate?
I always am surprised at how fast an hour goes by. And
Right.
you and I could easily spend hours discussing some topics. I've made a couple notes of future topics that you and I will hit in the future. So
good.
I'm going to put a little plug out there that Dr. Davis and a couple other of great myofascial release therapists are considering doing a treatment intensive at the Southwind Retreat Farm up in North Carolina. So we are trying to put some dates and some possibilities together for either later this year, early next year, or both, whatever they decide to do. And if you are interested in being able to work with Carol and a team of great practitioners in a more intimate setting, just let us know, send us a message. We'll put you on the mailing list when we send out the invitation for that. But just a plug there. I think if you're dealing with some chronic pain issues and some other just crossover between emotional, psychological, and physical pain, this is the right place to be. Very powerful interventions. Let's see what people are saying. Let's show it as we sort of finish up today. We know a lot of you have to leave, and we respect your time. Remember, you can always get these. You'll get a copy and a link to it. And really, this is mainly for you, and we appreciate always being able to have a takeaway from the Polestar Hour. And I want to personally thank Carol, my dear friend, for bringing your wisdom and your love and passion for our work that is always felt. And I appreciate you very much in my life and the life of our profession. You're a great pioneer and a great leader in our profession. If we can just bring up that last slide, and with all these things you're writing are so beautiful, and especially for you. These are two books that Carol has authored, The Patient Practitioner Interaction. This is what we've drawn today's lecture and discussion from. So there's a lot more inside there, and there's great practice ideas, and it really is for everybody, even though it's been written, primarily for the physical therapy profession in our sort of realm. It certainly has its application to all healthcare practitioners, and I'm sure it's used by nurses.
This is how you develop your skills. This is a workbook. Yeah. Patient Practitioner Interaction is a workbook. So if you buy this, you will get ability to practice your skills in active listening and I statements and communicating under intense circumstances when patients are depressed or perhaps inappropriate in their communication with you. What are the ways that you can respond to that in a healing way and still solve problems with them?
I always think of this as a maturation process of the healthcare practitioner. This is the maturation training to be able to be a great communicator as a healthcare or a movement practitioner. The other book up here is one that Carol actually asked me to write a chapter on Pilates. And Carol's been known for different types, bringing many of the, I don't like using the words as complementary or secondary, these are integrative therapies into mainstream medicine and rehabilitation. And so it's a great book that has many different, from Eastern medicine to body work, myofascial release, yoga, and et cetera, the list goes on, of various practices and therapies that we often can collaborate with in our communities to be able to bring the best.
And there are 4 science chapters in there that talk about the science, the cellular science that's behind all of these integrative therapies. And of course, foundational to this is the science of fascia and biotensegrity that's very, very appropriate to Pilates professionals. And when you understand the science, your practice will change, because you will recognize that fascia has the ability to heal itself, and that we're just inputting what's needed so that the fascia can come back home to itself, whether it's through the movement, through Pilates, or whether manual therapies. Mm-hmm.
Yeah. Well, Carol, our time is up for now, but we will be back together soon, I'm sure. Thank you, everybody, for joining us. Remember that we treat one person at a time. We accept all people equally. We believe in equal opportunities. Make sure that we are the ones that are showing forth the greater light and love. And we'll see you next week at the next Pilates Hour. Thank you again, Carol.
My pleasure. Thank you, everybody, for coming.